for anyone that's kind of like new this year. I'm one of the 5th years currently, just finishing up on obs and gynae. So it's been really nice to sort of recap some sort of very general abdominal pathology. So this is going to kind of proceed as a case and think about sort of the acute management and then like the diagnosis and then the sort of more long-term management of the condition. And then Marc is tying it into some cardio with a bit of an ECG quiz at the end. So your participation is very much encouraged. Put your microphone on if you want, or just write in the chat, and feel free to ask any questions at any point. I don't really have an SBA at the end, but I think, you know, in like a few sessions time, we could do some SBAs on some of the content we've covered this term. We did that quite similarly last term with our Christmas quiz, so it'd be fun to do that again. Cool. So this is a 62-year-old male that presents to A&E and has had a sudden onset left upper quadrant abdominal pain lasting for 5 hours. He's in a bit of a state when you see him. He's crying. He's very uncomfortable. He's had, from what he gives you in his slightly unclear history at this point, some previous episodes of pain that he's noticed have come on after meals, and he's presented to you now sort of around 6 o'clock. So you know, as he had lunch and then started to deteriorate in the afternoon. And he describes it as a squeezing pain. So what would be some kind of sensible things to do at this point in time? You know, you need to get your history, but your patient is really not sort of up to it. Does anyone want to sort of put in the chat, sort of thinking on like sort of thinking in the acute setting, which a lot of us won't have been in for a while, but I'm sure you all can come up with quite good suggestions. But I guess, you know, the big one would be giving this guy some pain management. The same would go with other pathologies. So like an acute gynae presentation or an acute chest pain or acute vomiting, you know, you're going to want to support your patient and get them relaxed. And actually this can quite dramatically improve their clinical picture. So you ask a bit more about the pain. There's no radiation, but he describes it as this 10 out of 10 intense pain. So you kind of catch a glimpse of a scar that's overlooking sort of the top right upper quadrant of his abdomen. Can anyone give me what this scar might have been due to, and like what the surgical like name for it is? I am not a keen wannabe surgeon, so you know this is like good revision for me as well. So if you saw this, what might you be thinking? Yeah, so cholecystectomy. Yeah, that's correct. That's really good. So yeah, the liver and the gallbladder's on that side. So if they've got that scar, it indicates that they've probably got a history of gallstones or liver pathology. So it's definitely worth asking them. Patients can often admit things that they don't think are relevant or happened many years ago. Does anyone know what the actual name of the incision's called? There's kind of only really a handful that you kind of need to know for like 4th year. I mean, they didn't come up in our exam, but like never say never, right? Depends on who. Oh, grid. I've not heard of that one. Anuj, can you like look it up, or Marc? I mean, Marc is also quite good at these because sometimes multiple people claim them, but the main one is like it's called like a Kocher incision. So,
I just realized I can't see the slide, so I'm going to leave and come back.
Yeah. To be fair though, like I think it is worth pointing out that like the surgeons at all of our hospitals will tell you that oh yeah, you should learn these scar names. They're gonna come up in your exams. They won't come up in your exams anymore. As in, the only advantage to learning these scar names is that like in an OSCE, if it comes up, you can look really slick.
And I guess like, placement. You know,
yeah,
it's important because general surgery is half of your rotation as an F1 and an F2. Learn it properly.
I think it's more important to know like what certain scars indicate rather than the names. Although there are like a few good names to learn, and I would say that the Kocher kosher, I don't know how to pronounce it. I can't do things. Is probably one of the good ones to learn if you were going to learn any of them.
Cool. So that's kind of your Socrates pain history. Definitely stick to that. I think for the OSCEs, I think it just gets you get into a really good formula with it. And it gets you to ask questions that if you miss them, you might really miss the diagnosis. So radiation can be quite important with certain pathologies. Cool. So past medical history, he's had some hypertension, some diabetes, previous transient ischemic attack, and osteoarthritis. He's had this cholecystectomy. Drugs wise, he's on some blood pressure control, a statin, aspirin, levothyroxine. He's got no drug allergies, which will always get you a mark in an OSCE, and so it's definitely something to think about. He lives in a ground floor flat, lives independently, so this is he's quite off his baseline. Cool. And then on your review of systems, you see that he's had weight loss of a stone in the last 2 months, which is pretty significant. So you're going to be quite concerned about serious pathology. Cool. So I think what's quite good is to kind of go back to basics with this. So what structures are in the left upper quadrant that could be a cause of his pain? I kind of chose the left upper quadrant and this pathology just because I think often, the right upper quadrant with the liver gets a lot of focus from clinicians and in questions, but this is definitely something. Yeah, so the spleen's a definite one. Yeah. So like what I guess that photo is almost misleading. Yeah, so the pancreas, yeah, it can be quite sort of epigastric and middle, but again, like the tail does go to the left side. So that's really good.
I guess it's also worth remembering that like the pancreas is retroperitoneal, so generally tends not to cause left upper quadrant pain, even though it's in that location. But yeah, anatomically, that's a good idea.
So then we've got the stomach. So classically, patients kind of present with this midline epigastric pain, but it's still something, individual variation and all that. And then you've got your splenic flexure of your colon as well there. And then it's always good to think about above the diaphragm, because the lungs do go down very far. And so a left or a right basal pneumonia can present with almost like abdominal symptoms. So it's definitely something to not rule out. Cool. So you finally get him kind of chill, well, as much as he can be. So you observe him, he's in great distress. Okay, maybe he's not chill. Poor wording. But he's able to move from the chair to the bed unaided. You notice there's some tar staining on his fingers. So I think this question, like, what does it suggest if he's able to move himself? So I think a better way for me to phrase this is like, if he was not able to move, to sit up in bed, if you press his abdomen and it's really, really rigid and he's really uncomfortable and screams out in pain, what would that suggest to you? Which would be quite an urgent finding. And yeah, Mark's pointed out urology. Yeah, so peritonitis. So has he kind of perforated? So it's quite reassuring that at the moment he's stable and he's not got this peritonism, but it would definitely, you'd be calling the surgeons if there was. So on the rest of examination, so it's always very important to be methodical and go, hand up the arm, face, and then down. So the kind of main findings there have been that he's tachycardic with an irregular rhythm, and also like corneal arcus. So for a kind of quick thing of like what these signs are, so this is, as I've just given away, corneal arcus. Can anyone name these other two findings that might be in conjunction with corneal arcus and like what the underlying problem is? So the photo of the guy's face, it's kind of these patches around his eyes. Yeah, so xanthelasma, yeah. And so what's, I guess, a continuation? What's the hand? Yep, so tendon xanthoma, and these go along with what? What's the underlying problem? What kind of causes them? Yeah, so like hyperlipidemia, yeah. So it's always good, especially I think if you're doing a cardiovascular exam, whenever you're worried about atherosclerotic disease and you've got these patients on a statin and blood pressure tablets and all of this stuff and they're elderly, it's definitely something to think about. Okay, cool. Right. So what investigations would you do for this man? So keeping in mind that he's got this abdominal pain with quite an extensive history with his high lipids, diabetes, hypertension, that sort of stuff. What would be some sensible things to do? So I think what's definitely something that they'll pull you up on in OSCEs is you've got to think about what you can do first. So if you go by, bedside tests first, what sorts of things would you do? You could literally say anything, to be honest, because you're gonna cast a very wide net at this point. So any bedside tests?
And someone who is very tachycardic, what would be a very good bedside test? If you see someone with a high heart rate. Yep.
Yep, ECG. Good. What else would people do? Yeah, so you do a blood gas. What would be, Jordan, what would be some things on a blood gas that would get you the most worried? There's like one specific thing that can suggest like end organ damage. Yeah, so a high lactate. So a high lactate indicates kind of a higher risk of poor outcome, basically, because that's suggesting that you're not perfusing an organ or multiple organs, you're pushing towards anaerobic respiration, and so you're producing a high lactate. So if this gentleman had that, you'd be incredibly worried about him. What would be some other sensible blood tests to run? If anyone wants to, I mean, completely up to you guys. If you want to put your mics on and just say them all, if it's better for you, easier on your hands. Yeah, so CRP would be really good. So that would go up in inflammation, infection, that kind of stuff. LFTs is totally sensible because, had the previous cholecystectomy and abdominal pain. And then, yeah, all your classics, FBCs, U's and E's. Yep, HbA1c, he's diabetic. It would be good to know a baseline. And diabetic ketoacidosis can present with generalized abdominal pain. So it's kind of not what we're thinking here, but we still want to manage his diabetes through this and not let that fall to the wayside. And then, yeah, lipids. And then, yeah, I think a troponin, it would, so troponins can, it's obviously for, cardiac ischemia, but it can go up in other things. So we probably wouldn't be surprised if it was going to be a bit high. To be honest, but you could probably still do it. So one thing that I'd also forgotten, which is very important, and they'll say no abdominal examination is complete without a PR exam. For this gentleman, what sorts of things might we find on PR that would be of great concern to us and also helpful for the diagnosis? And then, so melena. So if there's been any ischemia to the bowel, inflammation to the bowel, or any kind of trauma, that sort of stuff, you're going to get blood in the stool. And if it's, depending on the bit of bowel affected, it'll either be, very digested blood, so it will have that tarry look to it, or it'll be sort of more frank, fresh blood if it's lower down in the GI tract. So it would be negligent to not do one in this gentleman. So I think you could also definitely do blood cultures. I mean, if he's feverish and got abdominal pain, you can't rule out infection, so it's always good to do. You would do a chest x-ray, which we'll go on to in a minute as to why, and then a CT. Maybe not a chest abdo pelvis, depends on the patient, but I think especially like definitely an abdo one would give you a better indication at what level there's a problem. And then you're going to refer to either the medics or the surgeons, depending on what you suspect the pathology to be. So, so if we're thinking more about specific pathologies rather than locations, what would be some, and we're thinking about our vitamin D structure, which I totally have not done here, but what underlying etiologies could we have as a differential for left upper quadrant pain that we would be worried about? Yeah, so bowel ischemia. So in this case, he's got a very acute history, sudden onset. So that does suggest a vascular event. What about if it was kind of a bit insidious, bit of weight loss, bit of like fevers, night sweats in someone that's older? What could you think about that could then progress to left upper quadrant pain? So yeah, perforated colon definitely, and that would have multiple etiologies. So like, what are some, Laura, what are some causes, or like a cause of like why someone would have a perforation? So yeah, so I'm kind of asking multiple questions simultaneously, which is not like ideal, but yeah, malignancy would give an insidious picture. And then yeah, back to sort of perforation, you might be thinking about inflammation, infection. There's one particular infection which can cause swelling and edema of the bowel, which is Clostridium difficile. So in an elderly person with recent antibiotics, you could think about that. So I think it is definitely good to sort of think about the etiology of the causes. So obstruction would be a big one. So whether they've had a previous surgery and there's adhesions, there's a malignancy, or a mechanical one. So in young people or very elderly, you can get the twisting of the bowel. And then inflammatory, so your ulcerative colitis and Crohn's, above the diaphragm, as we've already said. And then, yeah, infection. And then we've got our vascular causes at the top. It is definitely something to bear in mind that you would, feel for the spleen with this presentation, and so you can get splenomegaly in a variety of conditions. So things like malaria would be one, and malignancy. So you'll honestly pick these all up by the end of the year, so don't worry. And I think definitely that your hematology teaching will give you some of these diagnoses in more detail. But as I think this just shows that you can have a huge variety of things, so you've got to cast quite a big net. Okay, so your patient, he becomes more unstable. He's dropped his BP. He's becoming a bit, personality's kind of shifted. He's becoming a bit sort of comatose now. His heart rate has gone up. And now he's not moving off the bed and he's in agony. What does this chest x-ray show? And this is kind of one of the reasons why you do a chest x-ray in someone with abdominal pain that you guys have touched on before. Yeah, so perforation. Can you just for everyone else, Davina, just say where you're kind of seeing the perforation? Yeah, so it's under the diaphragm. Nice, yeah. So basically, in normal chest x-rays, you're going to see your gastric bubble, which will sit on the left side. So there should not be air under this right side. And also the air under the left is pretty massive. And so you get, yeah, you can see the air under the diaphragm there. So that's called pneumoperitoneum. So it's another reason why if a consultant shows you a chest x-ray, do you think sort of outside of the lungs? So you're looking at the bones, you're looking at the diaphragm, and you're looking at the abdomen for what you can see. Cool. So another sign for perforation is this sign. Does anyone know what this is? And also I'd say like it's pretty impressive if you do know this at this point, but basically this is showing air both inside the bowel and on the outside of the bowel. And this is something else that they could mention to you. Yeah, nice. It's Irregular sign. Yeah. So it's this kind of double wall look. It took me ages. Some photos are better than others, but it's this double wall sign. So it's basically showing gas within the lumen and gas outside of the lumen. Cool. So their bowel is perforated. So what would you do? What would be your approach? I mean, obviously, step one would be have a bit of a panic. But like step two, you can tell I don't want to be a surgeon. Just be like, oh my God. Yeah, nice. So you're basically calling for help like immediately. So you've called for help, and then you've got a couple of minutes before they come down from operating on someone else. So what would you do in the interim? And this I'm mostly asking because like this is a classic SBA question where you can easily think about the last step. Yeah, when you should do your Dr. ABC. So you're still gonna check the airway, you're still gonna check the breathing. And then what would be some other good things to do to stabilize this patient? So if they've perforated, they're going to need to go to the surgeons. And if they're going to have, open laparotomy and all of the demands of that, what are going to be some great things that you can do that the surgeons are going to be pretty, that they're definitely going to ask for? So yeah, give fluids and antibiotics. They're going to be, releasing anaerobes all into their abdominal cavity. It's going to be, it's just going to be everywhere. So yeah, group and save. So yeah, group and save would be like definitely something you do, but like what do you definitely need to do, which is a bit of a step further? If they're going to go straight for a complex abdominal surgery, they're going to lose definitely like quite a bit of blood. So what should you do? What should you do additionally to group and save? So group and save is where they'll find their blood type, save it for later. So yeah, cross match. The lab will get those bags of blood ready for you. Yeah, fantastic. And then yeah, you're going to continuously monitor them. Nil by mouth is obviously, I mean, I've put nil by mouth, but like straight up, this patient is not going to want to eat anything anyway. But it is definitely something to bear in mind. You never know. Never say never. I guess for a more mild, for a patient with like mild abdominal pain, you do nil by mouth. And then, yeah, you're going to do your cross match and you're going to give them away to the surgeons, and then you can go back and have a cup of tea. Cool. So this is not real life. So we can go back before the perforation and we can think a bit about the history and the etiology. So I've highlighted here because I think it's quite useful in exams. You kind of pick up, and also in life, to be honest, you pick up kind of which key bits of info point towards a cardiovascular or a vascular cause of pathology. So this patient has kind of numerous things that suggest more of a vascular cause, which I've highlighted. And so, hold on one second, I'll get all this up. Cool. So the fact that it was sudden onset, it suggests an ischemic event. It would be the same with a myocardial infarction. It would be the sudden onset, severe pain, and then it's like squeezing in nature. is also indicative. And then they've got, you know, kind of all the classics of cardiovascular disease and their histories. They've got hypertension, diabetes, previous mini stroke, and then they're on a whole bunch of medications as well. And so also you want to think about which medications you're going to stop, which you're going to continue. So 1 second. So I always wondered this, and I just wanted to see if you guys know why this would happen. But like, why would it be if you've got bowel, you know, some kind of steady going bowel ischemia that's a bit chronic, why would you get the pain after you've eaten? Sorry, our fridge is super loud and makes these like phantom noises. So, so does anyone know why it would make, why eating would make the pain worse? Okay, so it's basically hypothesized that once you eat, you divert your yeah. So, I guess like he hasn't perforated yet. I mean, he wouldn't be. I don't know if he would be. I think if you've perforated, you're going to feel it basically, and so he wouldn't. He wouldn't have eaten kind of with a perforation. It's that the ischemia has led to a perforation, but it's instead, yeah. So the blood supply is diverted sort of to the stomach, and also just the metabolic demand of like consuming the meal, that you get this shift. So there's too much demand to too little supply is kind of the reason, if that makes sense. And so this squeezing pain that he's talked about is kind of what would be termed abdominal angina as well, which can be quite indicative. So it's kind of squeezing sensation. Cool. So a bit of like year one anatomy. So there's kind of 3 main blood vessels that you need to know: the blood supply to the intestine and the colon. So the celiac trunk is kind of the first one, the top one that comes off. And I think once you re-remember it, it's quite useful to know. So the celiac trunk supplies the stomach, the proximal duodenum, the liver, and the pancreas, so kind of all the top stuff. And then, so with that logic, what would the superior mesenteric artery supply? I realize we will have some budding surgeons in this session, so like it would be useful for you guys to revise your anatomy.
To be fair, this is anatomy that can really come up.
So in that order, we've kind of got to the proximal duodenum. So the superior mesenteric artery kind of does everything down to the transverse colon after that. So if you've got any kind of ischemia to the, like, for example, the jejunum, you're thinking about a pathology of the superior mesenteric artery that's kind of the source, either an embolism or atherosclerosis. So it is definitely something to think about. It does govern angiography and stuff where you're looking. And I think it also just helps to make a bit of sense of like why certain things happen. And then the inferior mesenteric artery does your left side of the colon, and it has a dual supply with anastomoses from the right. Another thing to bear in mind is that the rectum is actually quite safe from ischemia because it has a supply also from the iliac artery. So often patients will instead get ischemia from either pathologies of the other 3 vessels, but the rectum will be spared and salvageable in surgery. And these follow the embryological origins, so like the foregut, the midgut, and the hindgut. So if anyone wants to do a revision on that, feel free. Okay, so why is the left upper quadrant affected in particular? Does anyone know? There's kind of three main areas that are most at risk of ischemia, and it's kind of because we are in development, we're sort of made a bit wrong. We are imperfect, and our blood supply is imperfect. But this is something that could come up as to why this happens. So has anyone heard of watershed areas? So basically a watershed area is a location where the blood supply is very poor, or the blood supply is only from a handful of vessels. So if you knock out that vessel, you're going to knock out that bit of bowel. So the areas that are so-called watershed areas is the splenic flexure, which is kind of what is sort of hinted at in this case, so left upper quadrant pain. And it's because it's just, it's poor, kind of very susceptible to poor perfusion because of these poor collaterals. And then there's also the rectosigmoid junction down here, which can also have the same problem. And then also the right colon can as well. I'd probably say that, oh, sorry, one sec. I'd probably say that just bearing in mind these common places is really useful. And, you know, for example, like in Crohn's and ulcerative colitis, so Crohn's would more likely affect the kind of right side of the bowel, whereas ulcerative colitis, any of the colon, but mostly the left. So it does, you know, it's something to bear in mind with like your pathologies. Cool. So I think we can look at the mechanisms of both. So in general, I like to split it into embolic causes and like atheromatous causes of ischemia. So can anyone give me any risk factors for embolism? So there's definitely some cardiovascular ones, some rheumatology ones, if you're like me and Anush. And then there's some kind of I guess, modifiable risk factors as well. So quite a variety. There's one that this patient had, like in particular, and is probably the one that would come up in exams.
So which ones of these are embolic and which are atheromatous? Because you've given us both. So which ones are embolic first? Like, so just put the embolic ones first. Should we go over what embolic and atheromatous are to start with? Actually, that would be quite useful.
Yeah. So an embolus can be, so I guess like so thrombus is something that's commonly brought up, which is basically like clumped together platelets, and this can happen, you know, as part of it's basically part of normal physiology, right, to stop excess bleeding, but in certain conditions it can be increased. These can block blood vessels. And embolism can also be, you know, from fat or something else, but in the context of this, the most common is like a platelet clump that gets lodged in a vessel. And so there are certain states that would increase your risk of this. So infection, there's autoimmune causes, and then the kind of big arrhythmia cause was in this case. Whereas atheroma is more like it's, you know, your like lipid build up in vessels, which narrows the lumen, makes the arteries much less pliable to dilating, and they're rigid. And then, you know, I think you can get a combination of these two. So an embolism can come across and like block one of these atheromatous vessels. So it can be a bit of a combo. So embolic causes would be things like increasing age, atrial fibrillation, which is in this case hyperdynamic states. A recent heart attack is also a risk. Any kind of valvular disease that is promoting a thrombus forming. Cocaine and alcohol can cause hypertension, and thus can, you know, trigger the coagulation cascade. And then the big ones for exams would be lupus and antiphospholipid. Whereas with atheroma, you've got increasing age, high blood pressure, your hyperlipidemia, all your kind of classics, and a lot of these are modifiable risk factors. And so this would be some of the reasons why people would be put on statins. And it is also to bear in mind that alcohol can increase your risk of, it ups your lipids as well. So that is kind of just the same thing again, just in a different format in case it makes it easier. And then there's a classification of different types of gut ischemia based on which part of the bowel is affected. But in general, there's kind of only really 3 you need to know. And so you've got your ischemic colitis, so that involves your large bowel. This is relatively common, so 1 in 2,000 admissions is not like particularly low. They can present with PR bleeding and pain, but in general, like a lot of people can have quite mild disease and not die from it, but sometimes it can progress to this massive ulceration and they can get sick. But the main one, which is they're going to come in very acutely unwell and can die from, is the acute mesenteric ischemia. So this is small bowel ischemia. It's mostly from like atheromatous disease. And the main reason why people will be more likely to die is that they can present with this kind of generalized abdominal pain first, that then becomes localized, so can be missed. And then chronic mesenteric ischemia is kind of quite similar to ischemic colitis in that it's kind of this like long-standing, like low-grade elements of pain after food, but can progress. So you would want to medically manage these patients and fix all of your modifiable risk factors to prevent this getting worse and increased atheromatous disease. So ischemic colitis, like I think the main thing with all 3 of them is they can look quite similar to Crohn's and ulcerative colitis. So when you do an endoscopy, you can see ulcerations, you can see erythema. So a lot of it is kind of based on, I think, patient demographics. So a Crohn's or an ulcerative colitis patient will probably present earlier in life than these patients, and may not have the kind of postprandial pain. It might be more kind of continuous through the day. And so with ischemic colitis, mostly it's just supportive management, pain management, but they can progress to perforation. So then you would call the surgeons. Whereas mesenteric ischemia, they can more easily perforate. You're going to have a lower threshold to refer. And on here, you can see quite spectacularly on the CT that you've got like this double lumen, this almost like double lumen. And this is basically just like the bowel is so edematous because it's so ischemic that it's just swollen. And, you know, those bowel loops, you know, might end up ischemic and at laparotomy, which, I mean, you may not ever see this, but, you know, you're basically looking at dead bowel here. So that's all going to have to be removed. So I might skip this one because like I've already overrun a bit and Mark's got some really good stuff and some ECGs. So if anyone has any questions, pop them in the chat, but otherwise I'll pass over to Mark. Mark?
Yeah, if mine won't take too long, so we should have time to come back to the case as well. I wouldn't worry. I'm just going to talk about atrial fibrillation really quickly. Everyone and their grandmother will come to you in hospital medicine and probably have atrial fibrillation, so it's something you need to know about. Main things we're going to cover, we're going to recap the anatomy of the electrical pathways of the heart. I'm going to get you to tell me how you would describe a pulse, because that's very important and it's difficult unless you do it often. And it's important to know because it's something you need to be able to do when you're examining a patient. And then in terms of atrial fibrillation, we're going to define it, look at the ECG, and then acute versus chronic management. And then I have a fun little ECG quiz for you guys to do as well. Electrical conduction, pathway of the heart. We're going to start from the top and go down. Can people start labeling things from the top down? So what's the first arrow pointing to? Yeah, SA node. Then I can't remember which animation came next. So what are the three arrows or the arrow going to the left atrium?
To be fair, they have like the most uninteresting name in like medicine.
Yeah. I mean, there's a lot of uninteresting names in medicine, Anush.
No, I think this is the one.
I mean, it's between, if these are two pathways between two nodes. What do we use to describe things that are between two things?
Yeah.
So it's the anterior, intermediate, and posterior internodal pathways. And then this one going off to the left atrium, can anyone tell me? It's an eponymous one.
It won't come up, to be fair. We just put it in for completion.
So those are the internodal tracts, and the one going off to the left atria is the Bachmann's bundle. Bachmann's bundle is a branch of the anterior internodal tract that goes across the right atrium into supplying the left atrium. Given the AV node, this is pretty obvious. What's after the AV node? Again, another eponymous structure.
This one you do need to know for exams, though.
Everything underneath the AV, every SA node, AV node, and everything after the AV node, you need to know.
Yeah.
Bundle of His, very good. After the bundle of His, bundle of His divides into.
I think someone just said it. The bundle branches.
No, before the Purkinje's, bundle branches. So you have left and right, and your left bundle branch has an anterior fascicle and a posterior fascicle, and then you have your Purkinje fibers. Good. How do you describe a pulse? So there's 4 characters to look for when you're describing a pulse. And when you're at bedside teaching and your consultant is like, I want you to tell me what this pulse is. So rate, very good. Always start off with the rate. Character, yeah. Rhythm, there's one more. Volume, fantastic. Okay, so in terms of the rate, your normal is 60 to 100, then you're tachycardic if you're above 100, and brady if you're below 60. This can vary between ages, particularly in kids. Rhythm, how do you describe rhythm? I'm not going to do it now because it'll give away all my answers, but how do you describe rhythm of a pulse?
There's only 3 things you can say. That is the clue. At the bedside, anyway.
Regular? Well, yeah, sinus is regular. Regular, irregular, irregularly irregular. So, okay, there's regular, there's regularly irregular, and then there's irregularly irregular. So yeah, you pretty much got it there. Regularly irregular means that it's not a regular pulse. It's not sinus, but there's a pattern to the irregularity. How do you describe character? Can you give me a few descriptors for the character of a pulse? These are particularly important for AV block and valvular disease. Thready is more to do with volume.
Yeah, thready is like a weak
pulse. Yeah,
but
low volume pulse. Rising, falling. So yeah, so it's not rising, it's slow rising. Okay, and falling. I think you thinking of collapsing pulse? So slow rising pulse you see in aortic stenosis because it's a small orifice that blood is trying to shoot out of. So it's gonna peak. Its pressures are gonna peak in very slowly, and then collapsing is regurgitation. So as soon as it reaches its peak, once diastole begins, ventricle opens up, blood's going to flow back into the ventricle, and the pulse is just going to collapse it. Pulsatile expansile. Masco, you're thinking of abdominal aorta when you're describing the aorta, the palpation of the aorta during an abdominal examination. Good. The other ones are a bit more specific. So pulsus speciferens means there's two. There's a double tap during the pulse, and it's usually used to describe aortic stenosis again. And then pulsus alterans is alteration between a strong pulse and a weak pulse. Okay, and then volume, as was said, you have thready, which is low volume, and bounding, which is full volume, or hyperkinetic, which is full volume, or hypokinetic, which is thready and weak. Good.
If you say any of these in the fourth year, Oscar, you'll look really freaking good, because I mean, like, I wouldn't be able to recognize this in fourth year. Mark probably could, but like, yeah, I definitely couldn't. But if you can, that's amazing.
If you don't even have to use these specific terms. You as long as you know, in order to describe a pulse, you need to talk about the rate, you need to talk about the rhythm, you need to talk about the character, whether it's, it feels like it's slowly, it's slow to reach a peak, or whether it suddenly collapses down. And then you need to talk about the volume. Those are just the important things you need to worry about. The other thing I should mention is when you're talking about volume and character of a pulse, it's always a central pulse. So either carotids, femorals, or you can use the brachial as well. Okay, atrial fibrillation. It's chaotically irregular atrial rhythm. That's usually at above 300 beats per minute. Some texts say that it can be between 300 and 600 beats per minute. The AV node is, if the AV node is still functioning, it will allow intermittent pulses through to the ventricles, creating an irregular ventricular rate. So that's why you get your irregular pulse. And the atria don't contract synchronously. If you think about it, if they don't during the Wiggins diagram, right? Atria contract, and towards the end of diastole, and that pushes the last I think third of their volume into the ventricles to preload the ventricles. Okay, if you don't have the synchronous contraction, if it's just fibrillating and shaking the entire time, you're just relying on the blood leaking from the atria into the ventricles. So you reduce your preload to the ventricles, which reduces your cardiac output overall. So, causes of atrial fibrillation. This is something you should all be able to sing off by the end of this year. Common causes first. Can anyone name some common causes? I won't quiz you on the rarer causes. I'll tell you about them later, but the common causes first. MR and AR, yes, so valvular heart disease, particularly mitral stenosis, but we see mitral stenosis less during the less now than we used to when rheumatic fever was a lot more common. High blood pressure, very good.
Digoxin probably can. It can kind of do anything with the heart. It's hopefully you won't see it because it's used to treat atrial fibrillation. But
exactly,
I can see
it's used to treat atrial fibrillation in a specific instance as well.
Yeah,
which we'll talk about a little bit later. Thartic tachycardia, fantastic. Yeah, I was going to ask if you know any endocrine causes. So yeah, so mitral valve disease, high blood pressure, thyrotoxicosis. How about after a heart attack in ischemic heart disease? Do you think we would get atrial fibrillation in ischemic heart disease? And this is where you all start nodding your head and say yes, Mark. Much like HB would say, if you just answer yes to anything I say, then that's it. Yeah, you're on a winning streak. Good. So common causes, you've pretty much said a lot of it. You can also get them in PEs. Caffeine and alcohol, always important. And especially when you're taking a history about palpitations, always ask about caffeine and alcohol consumption. Okay. And post-cardiac surgery. as well. So it's something to watch out. It's if a lot of the hospitals that we rotate to don't have cardiac surgery. If you're ever put through a patient as an F1 or F2 in that post, it's something to be aware of. And then you have your rarer causes. So sinus 6 syndrome, 6 sinus syndrome, cardiomyopathies, hemochromatosis, constricted pericarditis. Yeah, actually, there's a good one. Have a Google of holiday heart syndrome, because it's a fun one that sometimes gets asked about as well. Signs and symptoms. Can anyone give me some symptoms that someone might complain of with any arrhythmia, really? Yeah, palpitations. Yeah, cloudy flutterings in their chest. Syncope, exactly. Like I said, their cardiac output is reduced, so they'll experience syncope, especially during fast episodes. Chest pain, very good. Yeah. If your heart doesn't pump properly, it can't supply blood to itself properly, and especially if it's pumping at a very high rate, it won't be. It will tire and build up lactate a lot more easily. Good. So those are pretty common ones. What about some signs that you might get? I've already told you one of them when we were describing pulse.
Yeah, like you basically diagnose AF based off that one sign.
Pretty much. I mean, there is another type. Yeah, irregular pulse. Very good. Also might be short of breath. And yes, it is irregular. There is another condition that can cause an irregular pulse, but it's not as common as AF. A third-degree heart block will cause an irregular pulse. Okay, so ECG, same way you would describe a pulse. It is irregular, but what's also the other finding of a ECG in someone with atrial fibrillation? See, yeah, absent P waves. So if your atria aren't contracting properly, they're fibrillating, they're shaking rather than a synchronous muscular contraction. You get F waves, which are fibrillation waves. So you get no discernible P waves. And on an ECG, where do you look? What leads do you look at to comment on the P waves? There's two leads you look at. Yeah, limb lead 2.
Not gonna lie, I just look at lead 2.
Yeah, and precordial lead 1. So V1. Good. Those are the only two. I mean, if you just look at those two, you're fine. Good. Okay. So the acute management of atrial fibrillation. Main thing, if a nurse calls you or someone calls you from the ward and they're telling you so-and-so is complaining of shortness of breath or chest pain or any problem, what is the first question you should have in your mind? Any problem when you come to review a patient on the ward? Yeah, exactly. Very good. Yeah, vitals. Are they hemodynamically stable? So is the patient stable or not stable? How are you going to tell if the patient is stable or not? What are you going to do to hint, assess if the patient is stable or not? Good. You're going to do your Dr. A, B, C, D, E. And lo and behold, on your examination of C, you find the patient has an irregular pulse. What investigation are you going to run? An ECG. Fantastic. Very good. And what else might you do during your investigations? I mean, something you should really do in general. So you run your ECG. You always put if their sats are liable, you put them on O2. Always think when you're doing ABCDE, look, feel, listen, measure, and treat. So in measuring, what can we do to measure things? So we've done our observations, we've checked our vitals, we've done our ECG. We can draw blood. We can take bloods. And it's something that's easily forgotten in the pressure of the moment. And I was doing sim earlier this week, and I forgot that we can do bloods while we do ABCDE. But don't forget, it's something you can always do. Main thing you're looking for is your adverse signs of shock. Is the patient cold, clammy, prolonged capillary refill time, depressed JVP, chest pain, very important. Are they syncopaic? And is there signs of heart failure? So they have acute pulmonary edema. If they're unstable, we're going to do a synchronized DC shock. So usually is 120 to 150 joules, and then I think the Oxford textbook says you can adjust that. You can increase the increments for two further shocks. But when you're asked a question, this patient has fast AF, they are hemodynamically unstable, your first answer is always synchronized DC shock. Well, your first answer is always call for help, and then once a senior comes, then you shock. If they're stable, it's a question of rate versus rhythm control. I always remember it as rate control first, and then you can rhythm control later down the line. Rate control, what do you think we're going to use to rate control a patient? What drugs can we give to a patient to slow their heart rate down? Fantastic, good. Beta blockers, calcium channel blockers, and there was one that was mentioned earlier before that we can use in a very specific instance. Digoxin, very good. Does anyone know which instance of atrial fibrillation that we can use digoxin in?
Ironic, because it actually comes up.
Yep, with HF. Fantastic. Yeah, so we can rate control with beta blocker, calcium channel antagonist blocker, like verapamil. It needs to be cardiac specific, and digoxin if they're in heart failure. Could you give atropine in this case? If you give atropine, you're going to make their heart rate faster, because atropine is for bradycardia. Exactly. Atropine is a antimuscarinic, so it'll block the parasympathetic system of the AV node, which will allow sympathetic stimulation to overtake. Yeah, that's how I always remember it. Good. Okay. In terms of rhythm control, if the onset is less than 48 hours, or they have been anticoagulated for greater than 3 weeks, so the onset of AFib is less than 48 hours, or they have been given anticoagulation for 3 weeks, then you can shock. You can so you give rate control, but you can also rhythm control using you can shock, you can DC cardiovert, or you can pharmacologically cardiovert. What 2 drugs can be used for pharmacological cardioversion? Does anyone know? So your choice is also based on something as well that I'll ask about. Amiodarone, fantastic. There's another one. Flecainide, very good. Good. So when can you use flecainide, and when should you use amiodarone? This is mostly this is a textbook answer. Well, in terms of the guidelines, it recommends the use of flecainide and amiodarone as well, in certain instances. So you can use flecainide if. Yeah, very good. So people with structural heart disease use amiodarone. People without structural heart disease use flecainide. What kind of drug is flecainide? Because you see, you know a lot about these 2 drugs. What type of drug is like a sodium channel blocker, fantastic. And I think, Anush, correct me if I'm wrong, it's type 1C, antiarrhythmic.
I think so. I mean, I knew this like 2 years ago.
Yeah.
I don't know it now.
It's there's 3 types, and I think it's 1C, class 1C.
Yeah, I think so too.
Yeah. But I've completely forgotten. But very good. Good. So you guys know all the answers. All right. And then amiodarone in the case of non-structural heart disease. Okay. Good. If the chest pain is greater than 48 hours, we rate control in the same methods that we use if it's less than 48 hours, either a beta blocker, calcium channel antagonist, or a digoxin. You delay rhythm control until greater 3 weeks of anticoagulation. And then in terms of anticoagulation, some of the guidelines suggest you give them heparin initially until you bridge them onto warfarin or a NOAC. Now, I always get confused as to when to use warfarin or a NOAC, and I'll come on to that on the next slide. And then, as always, with everything you treat or every condition that you see, always correct underlying causes. So underlying electrolyte imbalances, review underlying illnesses like pneumonia, or if they have PE, you always look for an underlying cause and treat that underlying cause. So chronic management, you split chronic AF into paroxysmal, which means it spontaneously occurs and ceases within 7 days. Persistent, it occurs for more than 7 days, and permanent, it just stays. Management is similar to the acute setting. You want to control the rate, you want to control the rhythm, and you want to anticoagulate. Those are the three mainstays. If you just remember those 3 things about atrial fibrillation, you are doing good for the exam. And in general, the rate control, same method as before. Rhythm control can be either you DC cardiovert, you pharmacologically cardiovert, or in refractory cases. Does anyone know what we can do in cases that don't respond to a synchronized cardioversion or pharmacological cardioversion? So if we medically throw the sink at a patient, who do we get involved afterwards?
I think it's also quickly worth mentioning, in elderly people at this stage, you might choose to not rhythm control them at all and just beta block them. But in a young person, if it's refractory, you do an extra thing. Anesthetics is a good idea, but this is one of the miracles they can't fix.
Yeah, this is one of the miracles anesthetists can't fix. Who usually comes along and is the hero of the OR more so than the anesthetist? Yeah, you surgeons. Yeah, so you can do surgery. I'm not expecting you guys to know what the types of surgery that we do. You wouldn't pacemake because you're not concerned about. I don't know if you pacemake actually, but I don't think you do because pacemakers are more reserved for bradycardias, aren't they?
Yeah. I was gonna say, so pacemakers and atropine for bradycardias.
Yeah.
Just as a general rule.
This is a type of tachycardia. So, although I'm not going to talk about it, this falls into a group of tachycardias known as supraventricular tachycardias. But good. So your rhythm control, like I said, elective synchronous DC cardioversion. You always echo first in case there's a thrombus. Elective pharmacological cardioversion, and then refractory. That's when we get the surgeons involved, where we ablate either around the pulmonary arteries or the AV node, because it's not theorized, but you can locate these fibrillating currents coming from the insertion of the pulmonary arteries into the left atrium. And then you can do what's called the Cox Maze procedure. So I was talking to a cardiac surgeon about this. It's basically where they go in. It's usually done during mitral valve repair or an aortic valve repair. They open up the left atrium and they they make incisions and scar around and create scar around specific pathways along the pulmonary artery orifices near the left atrial appendage as well. They're also currently looking at closing off the left atrial appendage, because in atrial fibrillation that tends to be the place where thrombuses will form. But there's multi-center trials going on for that at the moment. Don't worry, you don't need to remember all this. The main thing is, like I said, rate control, rhythm control, anticoagulate. Anticoagulation is very important to prevent thromboembolic complications. Can somebody name some thromboembolic complications?
Hint, it was the first half of this lecture.
Yeah. Yes, stroke. Stroke is more common than the first half of this lecture, but then also the first half of this lecture is also the next most common. You wouldn't get PE from atrial fibrillation because it's the sides of the heart. So yes, PE is a thromboembolic disease, but it occurs in venous circulation, which is the right side of the heart. And if you think about it, well, also, thrombi are less likely to occur in the right atrium than in the left atrium because the left atrium has extra space in the left atrial appendage. Bowel ischemia, very good. And then NOACs and warfarin, I always get confused between the two, when to use when, but the guidelines very simply say NOACs, non-valvular associated atrial fibrillation, and then one of risk factor of, I think, hypertension or diabetes. And then warfarin, always valvular AF. It seems to be the case. Good. There are considerations that need to be taken into account when you want to put someone on anticoagulation. And it's always a risk-benefit way up. So what are the risks of anticoagulating a patient? Valvular AF is, sorry, just very quickly, valvular AF versus non-valvular AF is AF in the context of valvular heart disease. So like we talked about, mitral stenosis used to be the most common valvular cause of atrial fibrillation, but now that we see less rheumatic fever, it's not as much. But yeah, valvular heart disease causing atrial fibrillation. That's what valvular AF is. So, risks of not anticoagulating a patient. If we leave this patient with atrial fibrillation on just rate control, what are we concerned about? We've just talked about it. Worry about thromboembolism. We're worried about this patient having a stroke, having mesenteric ischemia, having acute limb ischemia. What are the risks of anticoagulating a patient? What if we give this patient, what are we worried about if we put this patient on long-term warfarin? And sometimes we have to put them on very long. Yeah, very good. Bleeds, hemorrhages, GI bleeds. They fall and hit their head, cerebral hemorrhages. They're good. Hemarthrosis, they might bleed into a joint. So there are two scoring systems that the examiners like to ask about when it comes to considerations of anticoagulating someone with AF. And that's the CHA2DS2-VASc score and the Hasbled score. Does anyone know which one's used for which? Okay, so very quickly, the CHA2DS2-VASc score. Oh, where am I? CHA2DS2-VASc score for not anticoagulating. Yeah, so CHA2DS2-VASc score is the risk of someone having a stroke if they are not anticoagulated. So someone with AF, if they aren't given anticoagulation, what is their annual risk of having a stroke? And the Hasbled score is the risk of someone receiving anticoagulation having a bleed, or the risk of giving someone anticoagulation, basically. So you have to memorize these for exams, unfortunately. The CHA2DS2-VASc is very nice because it's an acronym for all the causes. And then a score of 2 or more equals a higher annual risk of stroke. The has bled isn't as nice, unfortunately, because it doesn't give a nice acronym. In your day-to-day lives, you're going to pull out Medi-Calc and you're going to open up it in Medi-Calc. But for the exams, unfortunately, you're going to have to memorize them. And I think the only way to do that is just sit down every now and then and just write out the acronym for CHADVAS, and then just like Bart Simpson does in the beginning of The Simpsons, just write has bled over and over and over and over and over again. But yeah, that's the main thing with atrial fibrillation. That's pretty much it. So we do have some ECGs. I'm wary that we've overrun a little bit, but if people want to stick around, there's 4 very common ones. The first 4 are very common. The last 4, 5 are more just for fun.
Shall we say? So I think. So I'll post the feedback link in the chat, and if you want to head off because it's late. If you want to stick around and go through these ECGs, we can do them another time. But yeah, just message us if you want to stick around and go through them now. There's like 5 of them or 6 of them.
This is just more for fun, because I found when I did my slides, I was worried I was coming up a bit short. So it's totally optional. It's more just for test your knowledge.
Yeah, like if not, we will just put them into another lecture as well.
Yeah, exactly.
So yeah, put a message in the chat if you want to stick around for like maybe another 10 minutes to go through them. If not, like no pressure to at all. Your game, cool. Yeah. Cool. So if you're gonna head off, just fill out. Just take 2 minutes to fill out the feedback before you do. It's super useful for us.
Yes.
And yeah, we'll go through these ECGs in a couple of minutes.
Yeah, I'll wait. We'll wait 2 minutes before we begin.
And also, like, it's recording, so if you do need to head off, you can still watch it back, because I'll make sure it's uploaded this weekend.
Here's the caveat: the first 4 ECGs are very common. Those are the ones you should know. The last 4 are increasingly more difficult, and are just to kind of scare you a little bit for fun.
The last one is stuff of legend.
If one of you can tell me what the last one is at your stage, I will be stunned, because it was only this year that I actually sat down to learn what it actually was.
Yeah, like a lot of people generally panic about ECGs, but the fact is, like I had like 8 ECG questions in my year, and like 6 of them were STEMIs.
That's all they really care about at UCL.
Yeah, they want you to be a safe doctor, so they'll ask you like the common stuff that tends to that can really impact like life. But yeah, should we start going through them? If you have any questions about anything we've done so far, just
fire away.
Message. But yeah, we'll start going through them for Jordan.
I know, Izzy, I know you've both seen these, so if like, you can feel free to jump in on some of them if you want as well. So, what's going on in this one? Nope.
Good guess. I can see why you would say that though.
I can see why you guessed it. There is a bit of a wandering baseline. Think simpler. Yeah, it is an SVT, but what SVT?
It is the commonest SVT. Is the clue.
It would be real specific with this.
This is the one SVT you need to be. So there's like 4 SVTs you need to specifically name. This is one of them, and it is the commonest one. You might not even have considered it to be an SVT.
Yep, there we go. Sinus tachycardia. Very good. Told you we're gonna start off with the easy ones. We're gonna get increasingly harder. So again, this is one you need to know for your exams, because apparently it'll come up like 4 or 5 times in the exam.
Honestly, it's ridiculous how much this comes up.
Very good. In which can you isolate the coronary that the STEMI is occurring in? Or if you tell me which leads. Yeah, so left anterior descending. It's looking, yeah, LAD. It's looking like it's the anterior leads, V1 to V4. Very good. Right ventricular hypertrophy. Close. If it's not the right ventricle, it's it's the left ventricle.
Yeah.
So left ventricular hypertrophy. And just so you guys, I'm going to put it in the chat, just so you guys have something to work off of.
It's worth mentioning. So this isn't a STEMI. I can see why you would say STEMI, because like it does look like there's ST elevation in the in like V1 to V3, but if you look at where the S wave ends, it already ends like way above the baseline. So that's why it looks like there's elevation, but it's not true elevation. Yeah, that's the criteria they use for like.
You can also get ST elevation. Well, not ST elevation, but you can get ST. Yeah, a bit of ST elevation with T wave inversion in left ventricular hypertrophy, and that's usually referred to as ventricular hypertrophy with strain. Good. Okay. Now we're getting. Hold on here. Why is that? Don't know why that's not appearing. Okay. This is this one's very important for exams as well. Can anyone tell me why this is hyperkalemia?
Mark, would you say this is the most important one for exams?
I would.
I think
I would say it's definitely one of the 2 most important ones. Yeah, tall tend to T waves. Very good.
Yeah. Very
good. Yeah, it's definitely, and it's something you should recognize. You should be able to recognize as soon as you see it, because it is something that is very concerning, because they could deteriorate. But yeah, I would say that and STEMIs are the ones in the exam paper that they'll ask you about all the time. Okay, this is harder. Now we're getting to the medal questions, the gold medal questions.
Yeah. So this could come up, but it would be like this would be like one of the differentiator questions that they only expect like 10 people in the year to get right. I can safely say before I saw this, I would not get this right.
Oh, very good. Wolf Parkinson.
Oh my God, amazing. Yeah.
Fantastic. Anyone know the criteria for Wolf Parkinson White on an ECG? Or what are the things you're looking for? Delta wave, fantastic. So shortened PR interval and delta wave. It's not a true shortened PR interval, it's just because the delta wave makes it look like it's a shortened PR interval. And then broad QRS complexes. Good. Well, Parkinson White. Now we're getting a little bit harder. T wave inversion in V1, V3. So hold on. V1, V2, and T wave inversion. So you can get, it depends on the age of the person who this ECG was taken from. So you can get T wave inversion in leads V1 to V3. particularly in pediatrics and in persistent juvenile T-wave inversion. So it could be a benign thing, but good spot. Difficult to point out the delta wave because there's no cursor on this, but
I'll find one. I'll put it in the chat.
Okay. Yeah, a neutral circle and drop it in the chat for you. It's very obvious in V1, V2, and V3. There's a slur to the initial start of the R wave. So, Laura, just answer. So, I hope that answers your question. It can depend. So, a T wave inversion in V1 to V3 can be acceptable in certain cases. Good. Okay. Anyone got any guesses for this one? No, I'm trying to remember which order I put these in. Right bundle branch block is correct. I think there's more to this. There is right bundle branch block. Yes, there is right bundle branch block, and there is T-wave inversion in again V1 to V3. This one is super subtle, so.
This is like a finals ECG, not like a year 4 ECG.
This is a digoxin toxicity. No.
I can see why you said that again. A good eye.
Because it kind of looks like a reverse tick. Yeah.
Yeah.
If I tell, it's very subtle, but look at leads 1 and lead 3. Limb lead 1 and lead 3.
So if I was to ask what is the most specific sign for a pulmonary embolus on an ECG, the answer would be this ECG. Sinus tachycardia is the most sensitive sign for PE, but it's not the most specific sign.
It is the most, but it's also the most common. So
yeah,
very
common
rarely,
sensitive. Yeah, that's good.
So you see someone with a PE present with this ECG as a very, but it's like when you see it, you know it's easy. Yeah, S1 Q3 T3. Very good.
Don't worry about this for like examples.
Yeah, you also got an inverted T wave, but that could be due to strain as well.
Yeah.
Good. But yeah, it's rare. If anyone asks you the ECG findings of a pulmonary embolism, always say sinus tachycardia. And then if they want the the more specific one, then you say S1Q1 Q3 T3. So there's three things. There's three abnormalities in this ECG that make up one specific entity. So you need to be systematic with this ECG, is my point. But you need to be systematic to interpret every ECG.
You saying there are three components may have given a bit of a clue. Also, you guys are really good at ECGs.
Yeah, I'm very impressed. I'm very, very impressed. Trifascicular block, fantastic. How did you come to the conclusion of trifascicular block? What are the findings?
My second question is, are you a budding cardiologist?
So Anush and I were talking about this. Trifascicular block is actually surprisingly common, particularly in geriatrics. It's just that it's not really picked up that much because people aren't systematic with how they interpret ECGs. So if you go through this in your system, rate, rhythm, axes, right bundle branch block, short PR interval, left hemi block, fantastic, very good. You don't need to calculate the specific hemi block, but you've told me that you found the left axis deviation, prolonged PR interval, and right bundle branch block. Fantastic. But yeah, if you take things systematically, you will you will always come to a satisfactory conclusion. I think it's awesome. People have a habit of when they're shown an ECG, they just spit out an answer immediately. But always be systematic. So recap axis. So normally, if you look at leads 1 and 2, you can also look at lead 1 and AVF. You can use these leads to calculate exactly the degree of axes based with some weird calculation. I never remember that. The easiest way to estimate if there's a right axis deviation or a left axis deviation is, are 1 and 2 both positive deflections, predominantly positive deflections? If 1 is a predominantly positive deflection and 2 is a negative deflection, then it is left axis deviation. And if they're both negative deflections, both 1 and 2 are negative deflections predominantly, it is right axis deviation. Now, in terms of hemiblock, whether it's anterior fascicle or posterior fascicle, I think anterior fascicle is axis deviation, left axis deviation of minus 45 degrees, and posterior hemiblock is greater than 100, minus 135. But
as you can tell from Marc's the specifics aren't that important, but like the important thing is, can you tell that there's axis deviation? And if you can recognize the fact that there is a bundle branch block, those are your two key learning points in this ECG. Even if it doesn't matter if you didn't get the trifascicular block, but if you can get those two things are really important just generally in ECGs.
Well, the third important thing is always be systematic. Always be systematic.
Yeah, and be systematic.
All right, this is the last one.
Oh yeah, like honestly, I didn't know the answer to this.
I was shown this ECG earlier this week, and I was like, I'm so confused. This looks normal to me.
This is purely for fun. Like, this is not for, this is for interest only, and for not for exams. It won't come up.
Do not panic if you don't get it. Hypothermia, yes, you can get T-wave inversion. You can get deep T-wave inversion. Posterior semi, I can see why you said it, but actually the ST segment looks like it's isoelectric with the baseline. Correct, you do get a deep T-wave inversion. Ischemia because of T-wave inversion. Yes, so this is a ischemia. It's an eponymous name for a type of ischemia.
That's a really good. That's a really good spot.
So there are certain conditions that you get deep T-wave inversion. Myocardial ischemia, hypertrophic cardiomyopathy, hypothermia, intracranial hemorrhage. These are the main ones that you need to think about when you see deep T-wave inversion. There is one, and this is the eponymous name one. Should we tell them, Anush?
Yeah. Because like it's just not coming up.
Does anyone know what Wellens syndrome is?
Or has heard of it?
Or has heard of it?
Yeah.
Wellens syndrome is critical stenosis of the left anterior descending artery, and it is really defined as on an ECG you get deep symmetrical or biphasic inverted T waves in leads V1 to V4. So remember how before I was saying you can allow for some degree of T wave inversion in leads V1 to V3. These V waves are very deep. They're greater than 3 millimeters in depth. So these you would consider pathological. So Wellens syndrome, critical stenosis of the LAD, deep T wave inversion. Don't worry if you never remember that. It's just something fun to show off.
Yeah.
But good. I'm impressed at how you guys are really good at ECGs. Well done.
Yeah. So wait, I'll stop the recording. I had a question.
Left